Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP examinations. We are two junior doctors based in the UK who have passed all three parts of the MRCP examinations within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on reactive arthritis under the section of rheumatology. So just a quick recap on the seronegative spondyloarthropathies. You will recall from our previous sessions that reactive arthritis is one of them, and the others are psoriatic arthritis, enteropathic arthritis, axial spondyloarthritis, and also maybe undifferentiated spondyloarthritis. You will also remember that all of these syndromes are associated with HLA-B27 as part of your blood test. So, what is reactive arthritis? Reactive arthritis is a sterile inflammatory arthritis that typically is followed after a gastrointestinal or a genitourinary infection, approximately about 1 week to 1 month. In terms of the epidemiology of the disease, it affects males far more commonly than females, with a ratio of about 20:1. However, if you do include cervicitis as part of the syndrome, then the ratio comes down to about 5:1. And it's important to note that the post-dysenteric arthritis has equal sex distribution. So based on that, the commonest sort of age range that you will see a patient with this condition would be between 15 to 40 years of age, and it is one of the commonest inflammatory arthritis affecting young men. Therefore, in a question, especially if they talk about a man in his 20s or 30s coming with a red swollen joint, you certainly need to be thinking about the possibility of the diagnosis being as reactive arthritis. In terms of the pathogenesis of the disease, as we discussed, this is from an antigenic material from the infectious organism that affects the joints, and the key to this is that sometimes organisms cannot be completely identified or grown, and as a result of that, this is not a disease that responds to antibiotics. Now, those of you who have gone through your medical schools, especially in the UK, you will remember that one of the school exam favorite is Reiter syndrome. And as you recall, this is a triad of arthritis, which is supposed to be a reactive arthritis type, conjunctivitis, and also urethritis. And the famous mnemonic of can't see, can't pee, can't climb a tree is what should come into your mind. So we talked about the condition to be a post-infection phenomenon, and the common infections that can cause reactive arthritis, as we discussed, are either going to be your genitourinary commonly, or your GI, and sometimes your upper respiratory tract infections can also cause this. So in terms of the common bugs that could be causing the syndrome, your enteric or urogenital causes are organisms such as Yersinia, Salmonella, Shigella, Campylobacter, C. diff, E. coli, especially the strain of 0157, and Chlamydia trachomatis. In terms of the upper respiratory tract causes, the commonest causes are Group A streptococci and Chlamydia pneumonia. I would put this in memory as it is quite, it's not unlikely for the test makers to hint as part of your vignette or your question stem into somebody who's coming in with a hot joint, and they ask you to identify the specific organism based on the history. So in terms of the extra-articular features of reactive arthritis, there are a few. However, a couple of them are really quite classic and exam favorites. So frequently it can affects multiple organs, from heart to lungs to CNS. And in terms of the effects on the heart, it can cause heart block and aortitis, which is quite well known with syphilis cause, and pericarditis, and finally it can cause aortic regurgitation. And in terms of the lung, it can cause pleurisy and generalized pulmonary infiltrates. And in terms of neurological, it can cause peripheral neuropathy as well as meningoencephalitis. The other extra articular features that can be seen in reactive arthritis are sercinate balanitis, which is quite commonly associated with a chlamydia case, keratoderma blenaragicum, which is quite commonly associated with the gonorrhea case. It can cause painless oral ulcers in about 25% of cases. Erythema nodosum, which is linked with, particularly with the case of Yersinia, iritis, which can be seen in the chronic cases of about 30%, plantar fasciitis and Achilles tendonitis are the other two that can be seen as an extra articular feature. So the differential diagnosis, which is very important for both your papers and for your PACES exam, is really a differential diagnosis of any acute monoarthritis. These can be gonococcal arthritis, septic arthritis, psoriatic arthritis, IBD-related arthritis, and finally a rheumatoid arthritis. In terms of the investigations that you would want to do for this, for the patient who is presenting with a suspected case of reactive arthritis, really the key is your history, because it's the history that's going to be telling you about the possible exposure to genitourinary or a gastrointestinal antigen in the recent weeks to a month. And frequently your lab investigations are quite limited in terms of helping you with this diagnosis. Of course, your ESR and CRP are usually elevated, and your HLA-B27 blood test may be positive in about 8% of cases. However, the most useful test would be, as any other case of acute hot joint, would be a synovial fluid, in which you would be ordering to exclude septic arthritis or any crystal arthritis such as gout. And in your active acute reactive arthritis, you will be usually getting a high leukocytes count with neutrophil predominance. Okay. Prognosis of reactive arthritis is really quite good. About 50% of cases have complete resolution. About 35% of cases will have initial resolution followed by a recurrence, and then unfortunately about 15% of cases you will get chronic persistent disease, and you are more likely to have a recurrence if you are HLA-B27 positive, or if urethritis is a trigger for your reactive arthritis. In terms of management of this condition, really it's quite conservative in terms of what can be given. Number one advice would be to rest the affected joints, and if you are particularly troubled by a mild disease, you can consider using NSAIDs. You could use a topical steroid and keratolytic agents specifically for keratoderma blenoragicum, and if you've got significant systemic involvement such as CNS involvement or lung or heart involvement, you could consider using steroids. So now let's do some questions. So question 1 is, which of these is not a typical feature of reactive arthritis? A, arthritis, B, conjunctivitis, C, scleritis, D, anterior uveitis, and E, urethritis. From the mnemonic that I mentioned to you earlier, you will recall that the classic triad of Reiter syndrome, which involves reactive arthritis, is arthritis, urethritis, and also conjunctivitis. And if you remember correctly, you will recall that scleritis is not a typical feature of reactive arthritis. Question 2 is, which of the following organisms is most likely to trigger a reactive arthritis? So A, you've got Chlamydia trachomatis, B, Staph aureus, C, Haemophilus influenzae, D, Group B strep, and E, Pseudomonas. If you will remember from the table that I showed you at the beginning of our talk, that one of the commonest organisms that causes, especially genitourinary cause with reactive arthritis, is Chlamydia trachomatis. So hopefully you got that correctly. And the final question, which is question 3, which of the following is not part of the typical management of reactive arthritis? A, conservative, rest the joint without any pharmacological treatment, B, ibuprofen, C, atorvastatin, D, colchicine, and E, naproxen. So if you recall from our talk earlier, you will remember that the hallmark of the management really is conservative. So resting the joint would actually be a very good and appropriate advice in here. And then for the rest of them, even if you don't know the exact method of treatment for this condition, you can kind of guess this question by an educated guessing and exclusion criteria. So you will know that option B, C, and E are all NSAID drugs, and the only one that's standing out really is colchicine, which is option D. And therefore, colchicine is not a typical management of reactive arthritis. And you will remember from our video on gout that it is the first line recommended management for acute gout attack. Thank you for listening to this episode of Bite Size MRCP. If you liked what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure that you don't miss our next episode. Let me know in the comment which topics you would like to hear in future. See you in our next episode.